It's my great pleasure to welcome a lovely team of people from the HMSA who've very kindly given up their time tonight to come and speak to us about hypermobility and PoTS. They've got a wealth of experience between them. So Lisa is the CEO of the charity. And then Kim and Joe are both volunteers, but with huge amounts of experience, both professionally and lived personal experience. So I will leave them to introduce themselves properly in a moment. If you've got any questions throughout, please add them to the chat box, and we will do our best to cover these at the end. Anything we don't get time for, we'll try and pick up if we can. The other thing I wanted to mention was PoTS Awareness Day, which is on the 25th of October, so on Friday. And we're just encouraging everyone to get as involved as you possibly can. It's been a busy month. The whole month of October has been Awareness Month. And on Friday itself, if you can share any of our videos or create your own video telling people about what PoTS is, anything like that, would just be really grateful because it's just a perfect opportunity to raise lots of awareness. Without further ado, we will start our session then. So I will hand over to Lisa and Kim and Joe. And like I said, pop your questions in the chat box and we'll go through those at the end. Thank you all.
Okay.
I think Kim's
I'll just share the slides. Yeah, there we go. Hopefully that's working for everybody.
Perfect. Thanks, Kim. So thank you very much for having us. We're absolutely delighted to be here. Thank you so much. We're just going to do some really quick introductions and then I'll hand over to Kim. As Joe said at the start, if you've got any questions, just put them in the chat and we will do our best to answer them at the end. So just in terms of quick introductions, I'm Lisa. I'm the CEO of the HMSA. I come mainly from a corporate and a charity background, but one of the reasons that I'm so grateful for you having us here this evening, because we love to talk about as many people as possible, because when I joined the charity, I sort of saw the job ad and thought, lots of people in my family are bendy, that's interesting, but didn't think too much about it. And then after a couple of years, which is how long I've been at the HMSA, volunteers smiling at me and sort of think the penny dropping, so many things make sense now, which is why it's so great if we can spread the word so that people have a greater understanding of some of the ways that PoTS and hypermobility might interact, some of the ways that hypermobility might affect you, and also lots of the things that you can do to help self-manage your symptoms alongside clinical care. So really the key people to listen to this evening are Kim and Joe. So without further ado, I'm going to hand over to Kim.
And I'm going to cheekily hand over to Joe to introduce herself, if you wouldn't mind. Lovely.
Of course. So my name is Jo Southall. I am an occupational therapist. I'm self-employed and work just via telehealth from my lovely home office. So my journey with the HMSA started a very, very long time ago when I was first diagnosed as a teenager. And I've been with them in some capacity ever since. My work now is basically around helping people to build like a health toolkit, a set of skills and strategies that they can use to self-manage as much as possible, as well as the skills needed to self-advocate, to, work as an expert patient and to function in whatever capacity you want to function in. So a lot of that comes from personal experience living with hypermobility and then slightly later being diagnosed with PoTS as well. But a lot of it is kind of a mix of personal experience and OT stuff. So yeah, we'll get into that later, I'm sure.
Thank you, Joe. Okay, so just a little introduction to me. I'm Kim Claydon, as you've been told. I am the HMSA Charities Professional Education Coordinator. I'm hoping you can still see my slides. Okay. I started off within the charity as a support group leader many moons ago, and then I went into social media manager for, I think it was like 7 years or something, and volunteering the occasional shift on the helpline. And then finally I did my retraining as a solution-focused psychotherapist and a clinical hypnotherapist, and kind of hopped over the fence, if you will, onto the professional side of things. So my main role now is assisting in organising events, training for professionals who want to know more about how they can support their patients with hypermobility, and supporting our medical advisory group as well. And this is why, alongside Joe, I'm classed as an expert patient, as I'm able to provide training to health and medical professionals, as well as we do stuff for patient education as well, in terms of self-management, education sessions for people with complex health conditions such as symptomatic hypermobility, how we can better manage conditions and symptoms, and focusing on themselves, their stress, their world, using the latest neuroscience of the impact of stress, pain, body, all of the brain body connections and stuff. I work very much as a whole person approach, and I believe this year it's 10 years I've been volunteering for the HMSA, so I'll give myself a little pat on the back for that one. So a little bit of a random fact about me: I've lived on a narrowboat now and have done for 7 years, and we've been continuously cruising the network for the last 5. So I'm on the Oxford Canal right now. And we've never been on this little stretch before, so coming from a completely different place for a new webinar for you. And I work completely 100% online with clients like Joe, telehealth wise, and it's wonderful to be able to do that me with health conditions as well. It means I can balance my time and energy levels really, really well. And I was diagnosed with hypermobile Ehlers-Danlos syndrome and PoTS, and a multitude of other things. They're kind of the main shoutiest ones that I have to manage. But for those of you that don't know exactly what HEDS is for short, it's a heritable connective tissue disorder, which means I've inherited wonky genes like Joe. All of our collagen in our body is faulty, too stretchy. Most of the things that I struggle with is kind of widespread pain, subluxations frequently, partial dislocations, which that's what subluxations are. We have full-on dislocations, poor wound healing, chronic fatigue. I have also swallowing issues, slow gut motility, and a multitude of other things, and we'll go into that a little bit more later on. It took 11 years for my initial symptoms, when they started after a car accident, to get my diagnosis. And unfortunately, that is quite common. I think the average to diagnoses now is randomly about 10 years. Which is not great. This is exactly why we do what we do, educate professionals and things to get the word out there so we can get that diagnosis much, much quicker. And for a lot of us, which I'm gonna guess you guys get a lot as well, we get told a lot by health and medical professionals that, you know, it's all in your head, grin and bear it, push through, and so on. We all kind of get those, we've all got those sentences that have been said to us at some point or another. Now, before all of this, my full-time job was an ice skating coach, believe it or not. I skated for many years. Initially, being hypermobile was an absolute advantage. And I will, oh, hang on, I'm going on the wrong slide there. Bear with me. Oh, I did move them around as well. 2 ticks, sorry guys. I'll have to share again.
Just while you're doing that, Kim,
Oh,
I'll just jump in and
there we
say,
go.
because I forgot to say at the start,
Yes.
we will be recording the webinar and it will be up on our YouTube channel afterwards. So if anybody's frantically writing notes or anything, or thinks, oh, I'd like to go back and listen to what was said there, we will be able to do that. Thanks, Kim.
Excellent, thank you. Okay, so for me, in particular, ice skating was, you know, being hypermobile was definitely an advantage with my ice skating, and I was well known within the community for one particular move. So I thought we'd just share this little video for you all. And like Joe, you know, very sporty as individuals, my hypermobility was definitely a useful thing. Um, until unfortunately the car accident kind of kicked everything off, and I just got more and more symptoms going on, and that's quite common for a lot of people. We're also seeing that link with people getting COVID and then noticing that they've got this symptomatic hypermobility going on. There's very much a crossover going on with these symptoms now after a COVID infection. So this is really why I mention it. You know, we can have a fairly normal life, we can get something, and then we become very symptomatic, and that happens for a lot of us as well. So I'm going to go on to the next slide that I should have gone on now. So for a lot of us, I just want to, before we really crack on into the kind of nitty gritty of hypermobility, I would like you to join me, if you will, into working out, you know, what if you hear the word hypermobile or hypermobility, what springs to mind for you? Because I know there will probably be a lot of bendies hiding in the audience here tonight. So you can use the QR code to scan to join in and just type a word, and we'll have a bit of a word thingy come up. If you're not able to scan the QR code, you can go on to slido.com and you can put in 589 super bendy. Double jointed. That's the really, really common one. Here we go. Oh, I love this. This is so cool. Because I know we have a lot of crossover with comorbidities, you know, those kind of conditions that are associated with the type of conditions that we have, that we tend to get a lot of. So Joe and I are both diagnosed with PoTS as well as hypermobility syndrome. Lots of accompanying symptoms, tight, wiggly. Oh, like wiggly, that's a really good one. Sore joints, achy, pain, fatigue, absolutely. I like the very bendy. We've had that a few times. Excellent. Thank you. This is lovely. Wobbles. Interesting. Yep. Gastro issues. Absolutely. Love this. Thank you, everybody. We'll give you access to this as well afterwards because I think it's quite nice to share. All coming in. I'll just give you another few seconds or so. Interesting shoulder collapse. Night. Yeah, absolutely. Thank you ever so much, everybody. There we go. Okay, so hopefully this is gonna, yeah, me and my slides working and me remembering to do my slides. Okay, so starting with the epidemiology. Now, epidemiology basically is the study of occurrence and distribution of health and disease in a defined population. So within the adult population, the prevalence of hypermobility is 10 to 15%, okay? And around 1% of that 10 to 15% are symptomatic. But we know this may actually be higher. We struggle with getting the diagnoses. So a lot of people can be going through life without that diagnosis. So we think it could actually be higher. It's predominantly affecting females assigned at birth, and the bendiness can diminish absolutely with age, which then can make it really difficult to identify in older age groups. And this is why it's important for the health and medical professionals to look at a patient's history as well as that family history as well. And it does have a racial bias towards African and Asian racial groups as well. It has an inheritance, which we call autosomal dominance, with a variable expression. It sounds very, very wordy. Autosomal dominance is the way that a genetic trait or a condition can be passed down from parent to child. And it's around 50% chance to be passed down from parent to child as well. So in my case, my mum and her mum, both bendy, and my dad has it within his family as well. So I got super unlucky with my genetics, and it just gave me all the things after the car accident. Even though I was always bendy, I did injure a lot, and I had some things going on. You know, I just got really unlucky with the genes, and I know Jo says that as well. She was in the unlucky category with the genetics as well. The variant expression simply means we are all affected differently. So same condition, different symptoms. All right. So just going back through the history of how these symptoms emerged, we have this lovely, beautiful triangle. So it emerged over the last century. We have Ehlers-Danlos, which is the very stretchy skin, clicky joints that sublux, that partial dislocation. That's what that sublux is. Or they full on dislocate. And then in the 60s, it became clear that this was associated with musculoskeletal pain, and also then prolapses as a result of stretchy collagen. And prolapses is when some of our inner bits try to push outwards due to the laxicity. So the inner bits try to become outer bits, unfortunately. And this could be things such as the vagina, which is known as a uterine prolapse. Another one that's well known is a rectum prolapse as well. Not very nice at all. Subsequently, we have chronic pain syndromes, anxiety, and things as well. CVS dysregulation means cardiovascular dysregulation, such as autonomic dysfunction, including PoTS, orthostatic tachycardia syndrome. PoTS for short. We basically we get an exaggerated cardiovascular response to change to postural stimuli or other stimuli. So, my standing up makes me feel rather rubbish, heat intolerance and things like that. GI dysmotility is gastrointestinal dysmotility. So this is meaning a section or sections of the intestines do not work correctly. So for us, the muscles that should contract and move stuff along can slow down or even stop working altogether, unfortunately. Then there's rare neurological things that are associated, like Chiari malformation, which was previously known as Arnold-Chiari, where the lower part of the brain tries to push down into the spinal canal as well. And then some symptoms of this are headaches. They're usually felt at the back of the head, and they may be brought on or made worse by coughing, straining, sneezing, bending over. There's a lot of neck pain involved, dizziness, balance problems, muscle weakness, numbness, tingling in arms and legs, blurred vision, double vision, sensitivity to light, swallowing problems, hearing loss, tinnitus, feeling or being really sick, difficulty sleeping, insomnia, and clinical depression. There's a whole bunch of stuff that goes on with Chiari. It can be quite nasty. So one of the new kids on the block for us that we've identified is, or in this identification, is mast cell activation. Even newer, I'm having a chat with Dr. Ball in regards to this, which is he's kind of chief in charge of our medical advisory group. We'll be discussing about how we can update this, but the newest kid on the block is that we have this high prevalence of neurodiversity within our community as well. I think the latest figures are showing that around 80% of symptomatic hypermobility people are neurodiverse in some shape or form as well. So that's the kind of background of how it's all kind of come together as to where we are today. So here we have a Venn diagram, just to kind of orientate yourself with this diagram on this slide. We have a large group of asymptomatic people in the community. So no symptoms, they are just hypermobile. Like I was, but there was stuff going on before the car accident, but I was just bendy, double jointed. And on the right, in the yellow, we have 12 types of genetically inherited EDS. And in the purple are some other rare disorders such as Marfan's, Osteogenesis imperfecta, which demonstrates hypermobility. There's other conditions there as well. We'll talk a little bit about those today because they're really interesting conditions, and we'll mention those as well. In the middle, we have what is known as a spectrum, which includes hypermobility spectrum disorder and hypermobile EDS or Ehlers-Danlos syndrome. And what you may notice is that there is that overlap of common symptoms or co-occurring conditions such as PoTS, MCAS, gut issues, etc. Oh, excuse me. Just so you can see some of the conditions a little bit clearer, here we have the whole bunch of different types of hypermobility. Some hypermobility syndromes, or HMS, is an umbrella term for the conditions that create that symptomatic hypermobility. So there's a whole bunch of symptoms that can happen with symptomatic folk. Some we have discussed already, a few new ones thrown in there. So what I'm going to go on to here now is a bit more of that symptomology. There's this also, we've got this local anaesthetic resistance that we have as well. There's all sorts of random stuff that we do struggle with. But as I say, everybody is completely different when it comes to this. You know, there's no two people that are exactly the same with their hypermobility syndrome. Poor posture is very, very common. You know, floppy is comfy, so it takes us a lot of effort to just sit up, being upright because of the laxity in the joint. Our muscles have to do the work of the joints to kind of hold us together to do the joints job. We can get breathing dysfunction because, you know, floppy is comfy. We don't fully inflate our lungs, and we can actually, as a result of that, trigger our PoTS more because of not breathing correctly. But yeah, so there's although we've mentioned a few symptoms already of what I've dealt with, this is a kind of even more that we can deal with as well on top of that. Okay. So we're going to do a quick test. If that's all right with you. So if you're feeling like you could do with a little wriggle, this is just to kind of, I would like you to kind of give yourself a score, all right? And I'll ask you for your numbers, and you can join in another slide shortly, another Slido. So one of the ways in which medical professionals try to diagnose individuals is through the use of this Beighton score. Even though this was not intended as its use, and it isn't massively accurate, especially for people who are not so bendy anymore. As we've said, as we grow older, we become less bendy, but that doesn't mean we're not having other symptoms of hypermobility syndromes. So I thought it might be fun to see what your Beighton score is, mainly because we have this increased prevalence of hypermobility with people with PoTS as well, pop up in the community. So I thought it'd be nice to kind of have a little bit of a move and a play. Now, in order to score 1 point, each little finger has to bend back 90 degrees or more. Okay, and that's 1 point on each hand. So both fingers have to do that. Okay. Now the thumb one is a weird one. So you have to kind of go palm down and then stretch down and then bring your thumb to your forearm. I can see Lisa's doing that already. Yeah, and that's both thumbs that have to bend down. Elbows, palms facing upwards, and we go that way. Okay, and they have to be 10 degrees or more in order to get a point, and that's both elbows. And then knees while standing, probably not best for POTSy people. So make sure you're leaning against something. But whilst you're standing, we want to see if your knees bend back in any shape or form. This is the one probably not so much for POTSy people. Make sure you have got support of some description. But finally, it's to see how flexible the spine and hips are. So while standing with straight legs, to bend forward and place your palms flat on the floor, and that gives you 1 point. So it's 2 points for everything else bar the spine, which is 1 point. A normal Beighton score is considered between 0 and 3. And if you're hypermobile, then they consider it bendy as 4 and 9. So if you would like to click on the option and see where everybody's sitting, that would be really, really fun for me. So if you can use the QR code to join in the poll, that'd be great. If you can't use the QR code, again, just go to slido.com and then tap in the number and give us your, here we go. Oh, I wondered if you were all going to be kind of going at the higher end of the scale, but it'd be interesting to see how we turn out. Joe, you look intrigued. It's fascinating, isn't it? It's very interesting. So we have got some bendy people hiding in the audience there. Fabulous. Just give you another few seconds. And then I can grab a drink as well. There we go. Thank you. Now the poll should stay active for a little bit anyway. I love this. So long. How am I doing for time? Cool. Thank you, everyone. So it should stay active for a little while. So do feel free to screenshot if you haven't got the correct device to have a little play now. So you can still join in afterwards. That's okay. IT. Thank you ever so. All right, now So as you can tell, the Beighton score only works on 9 particular joints. Some people can have a low Beighton score and still be classed as having symptomatic hypermobility, but unfortunately, we're still having that battle with people undiagnosing, because if they're not getting the correct Beighton score number, they're being dismissed. So we're now trying to roll out as well some other things that within with GPs, rheumatologists, and all sorts as well. So if you are the more mature variety of human, so you're more mature like me, so although my bendiness seems to have remained, I'm very much like my mum as well. For some people it does decrease, as we say. So for them to try and do the Beighton score, it's not going to be very accurate for them. Doesn't mean they're not symptomatic. So we now have the 5-point questionnaire to support the Beighton score. So even if they, the medical professionals insist on using the Beighton score, we're going to try and give them this to have a to kind of think outside that box, that it's not just those particular 9 joints that mean that you have that hypermobility syndrome. So thank you for joining me with that one. I do love to get you all involved, so thank you. Okay, so moving on to the spider screening tool. This is oh so shiny for us and new for us, and it's very, very exciting. I think it has now finished and completed its validation process, actually. And in fact, the adult research validation is completely, so if I'm not mistaken, that's all done now, isn't it? Yeah. So this is to gain even more insight into the patient's experience, find out what else they're struggling with, and then work out with a multidisciplinary team how to support them, starting with basically the shoutiest problems first. So what they're struggling with the most, and kind of like, I almost see it as like herding sheep and trying to like work on those issues and trying to bring them back into the center again, because we have such a multidisciplinary team required for a lot. There's so many things and aspects going on. It's trying to kind of get everything back under control. NMS and pain are the biggest issues. That's neuromusculoskeletal, if I'm not mistaken. The biggest issues for the person here, we know this can have a huge impact on everybody's mood and mental health when it comes to this as well. So you get a lot of neuromusculoskeletal pain, and then anxiety and depression absolutely go hand in hand with these types of ones. But then medical professionals can refer to the right people, and so they can get the right support. So yes, they may need pain clinic, but they also need psychological support as well. And then they can follow up later on, see how the sheep have been herded in. Has it gotten better? What else might be shouting now, as because those things have calmed down? So it's a great way of us having this way of utilizing the multidisciplinary teams. Now the second person here is struggling with the neuromusculoskeletal issues, fatigue. So the clinician can start focusing on those. It just gives us a really nice way of helping with that multi-systemic approach that we need to look at for these types of conditions. So I just want to show you the sort of things that we work on in terms of trying to get health and medical professionals to understand, it's not rocket science, in terms of what we need support with, and how to identify it. It's just making sure they're aware of it. Unfortunately, it does get dismissed a lot. We do get told a lot of our stuff is all in our head, so we're constantly making new things, very quick, easy things that they can print off and just have access to. Try to be nice and punchy and visual, and I know you guys will be doing exactly the same for PoTS as well, and dysautonomia and all of those sort of things. We need to be able to be very quick and accessible with information, because we know GPs get such small amount of time to be able to kind of sort out and help you, that they need like quick information. So we're constantly trying to make easier access information for them as well. This is just a visual representation for one of our fellow volunteers of what their condition's like for them. And you can absolutely see it is a multi-systemic thing. And although you know, very much like PoTS, it's an invisible condition. You can't see a lot of the time what's going on unless your heart rate alert is going off, which mine does when I'm eating my dinner. Before my PoTS, you know, big dinners is one of my triggers. I know this. But these are the sort of things, it's quite nice to be able to visually see some of the things that stand out for this particular person. And I like the fact that they've done the knotted neck, because that's a really common, you know, that kind of neck and shoulder pain. And it'll be interesting actually if your audience as well identify with any of this, because it's very, very common. And PoTS, I know the butterflies in the chest, I get that sometimes, and things like that as well. Okey-dokey. So we're just going to move on to Marfan's. I'm going to whiz through the next little bit, and then because we want to give you plenty of time as well for questions and things as well. So the three most common structural building blocks that constitute the connective tissue are proteins, collagen, a fibrillin, and elastin. So for people like me and Joe, HEDS, it's the collagen that is faulty. The collagen is the problem for a lot of hypermobile people, myself included. And then we've got Marfan's, it's actually the fibrillin too. So they have, and the fibrillin, you know, these all have an important function in maintaining the elasticity and strength of these tissues. And in Marfan's or MFS, there's not enough fibrillin in the connective tissue. The biology of this is much more complex than it just being about the physical amount of fibrillin present. It's also about how the fibrillin interacts with another, and how it influences normal biochemical processes within the connective tissue. When these interactions go wrong, the tissues can become very weak and very fragile, and fibrillin is found mainly in bones, at the aorta, which is the main artery, and the eyes. So hence, these are the parts of the body most prone to the complications with Marfan syndrome. Now, the clinical features of Marfan's vary considerably from person to person. Some people only having mild features. Everyone with Marfan's is born with the condition, but it may not be obvious before the kind of teenage years, during a very big growth spurt usually. And to add to that complexity, some of the complications may not arise for many, many years, and indeed they arise even at all. So every case has to be managed very much on an individual level. And these images were very greatly given to us for permission to use from a lovely, lovely volunteer we had with us. She's moved on to doing photography and all sorts of things now. She does some wonderful stuff. But this was one of the complications she had as a result of her Marfan's. She had to have her spine surgery done due to scoliosis, which is very, very common as well. Okie so just some of the features, and this is her long arm span. Okay, it's incredible arm span, and they show very, very long slender fingers and things as well. So just some common things, some common features that you may come across if you see anybody like that. Maybe think Marfan, maybe try and go and see a GP. It's important that people with Marfan absolutely are monitored, because the fibrillin going wrong, particularly that aorta and the eyes and things, it's important that they are managed very, very closely. Okay. So the where are we? There we go. We're going to go on to osteogenesis imperfecta. So OI, you may know this actually as brittle bone disease, and that's what it's mostly known as, rather than osteogenesis imperfecta. But it is absolutely much more than brittle bones. It's a group of inherited conditions which are characterized by fragile bones and fractures that arise spontaneously or after very, very minimal trauma. It's also associated with weak teeth due to poor dentine. Blue sclerae, I think I've said that right, which is the bluish tint in the white of the eyes. Kyphosis, which is the forward curvature of the spine, and scoliosis, which is the sideways curvature of the spine. Very easy bruising, bleeding, hypermobility, weak muscles, progressive hearing loss, bone deformities, which then may lead to chronic pain as well. So a person that is born with this disorder, and it can be affecting their whole of their lives. Males and females assigned at birth, and racial groups are actually affected equally with this one. But overall, it is a rare condition, being found in around 6 out of 100,000 people, which means there are likely 3,000 to 4,000 people in the UK with this condition. Okie dokie. And that's a review of just the associated symptoms with a lot of the hypermobility conditions that we're seeing, particularly with HSD, HEDS, and so on. So yeah, just wanted to give you that as well. So I think that's me done, and I'm going to pass you over to the lovely Lisa. Yes, thank you. I hope you found that interesting. I'm going to pass you over to Lisa now. Thank you.
Thanks so much, Kim. I'm going to be really quick because I want to have as much time as possible for questions. But I just wanted to tell you a little bit about the HMSA and what we can do to support people. So we're here to support everyone with symptomatic hypermobility, whatever the cause or however mildly they may be affected and whether or not they're diagnosed. So as I said at the beginning, I came from a family where everyone was really flexible and everyone was really bendy, so didn't really think about it. And going back to the Beighton score, which Kim did, I can ace the Beighton score, but there are people that we work with who actually have far more, severe symptoms. So we're really here to support everybody, whichever, however severe your symptoms are, because there's a lot people can do to self-manage. I was the girl who was always really flexible, was always in the gymnastics club, but was always last to be picked for rounders because I could never hit the ball. So really clumsy, Joe will talk probably more about this in terms of proprioception, never knowing where my limbs are in space. Joe made me laugh the other night in a session talking about, catching the sleeve of your jumper or your dressing gown on a door. And I was like, oh, yeah, I do that all the time. So there's all these kind of things that can be at the severe level or at the mild level, but still there's a lot of things that people can do to help themselves, and I wish I'd known a bit younger, might have actually done some muscle strengthening as Pilates, so I wouldn't be at the podiatrist now about my wonky ankle. So we really are here to support everyone. And as Kim said, there's a whole range of symptoms, and actually even a few conditions that whereby you might be flexible, even a few more like Down syndrome, cerebral palsy. So we're really here to support absolutely everyone. So there's space for everywhere. In terms of things that we do for individuals, we have a membership program where you get a range of all of our events then are free. You get the journal, all sorts of extra things, but we do try and run a lot of events that are also free for everybody. One of those key things which I'd like to plug is that on the third Thursday of every month, Joe Southall and sometimes Joe plus a guest, we have an Ask the OT session, 7 p.m. third Thursday of every month, completely free. And she's there to sort of answer any questions that you might have. And that's a really great session. And also Joe is around on November the 12th for a completely free session on joint protection. So if either of those are of any interest, do come along. For our members, we have a range of additional things. So Joe and Kim again in January do their Living Well set of 5 seminars for members, which go through things like weight management, pain management, managing your hypermobility, sleep, diet, all sorts of things, which are really important, because one of the focuses of the HMSA is not only the research and raising awareness among clinicians, but also we know about the time to diagnosis. We know about the issues with getting appointments, waiting lists. So we're really big on self-management and the things that you can do to support yourself along the way. And one of Joe's specialisms is also pacing. So, and I think one of the other things that we do, which I'm sure is important to, and you'll all understand on the call with PoTS, is, as Kim was mentioning, being told, well, you're just making it up. Oh, well, you're a bit bendy, but so what? So we also provide a community of support from people who get it. You can send in a question, you can come to a session, and you'll get to talk to people who really understand what you're going through. So we're always calm, we're always solution focused, and we're really here to deal with whatever issues you have. We've got a completely free helpline, email, support on social media. Send us in some questions. So you know, whatever you need, you know, we'll do our best. We are small, but we'll do our best to help. And we also share research and try and boost participation in a wide range of research projects. Coming on to some of the kind of examples of things that we do, we're very much led by volunteers. Joe and Kim are just, well, they're really key volunteers, but we're really lucky to have such a wide range of people who give their support and time and expertise. And so the volunteers are really, really important. And again, as I said before, it's all people who, you know, really understand where you're coming from. Next slide, please.
Oh, sorry.
That's absolutely fine. So as I said, we're very focused on self-management. We really hear for absolutely everyone, and we can probably move on to the next slide. I just want to quickly give some examples of some of the events and the types of things that we do. So as I said, we've got the lots of free events, but just to give you an idea of some of the other types of events that we run, we've got Jeannie de Bon, who's very well known for her work with sort of exercise movement, similar to Pilates, but focused particularly for people with hypermobility. Kim touched earlier on the links between hypermobility and neurodiversity. Jessica Eccles, that's who spoke for us recently. That's her key area of expertise, but she's also done some really interesting research on hypermobility on long COVID, which she presented on for us recently. So we do couple of events, if not more, every single month. So do keep an eye on our Facebook feeds and do sign up to our emails as well, and you'll find out. As I said, this is Jo, Ask the OT, third Thursday of every month. These sessions are really great, and I have to say, I'm still learning lots. I go more to my own benefit than the practice. She's really great, so do come and listen. Next slide, please. Yeah, and we also do have a lot of resources online, both for professionals and for people affected. So do, if you're in an appointment, also feel free to point the professionals in the direction of our website. That might be helpful for you if you're getting a professional that's kind of, is that a thing? So absolutely got support for professionals as well as for individuals. So always feel free, point them in our direction. This is how to find us on social media. So do get in touch. We often get a lot of questions coming in by social media. That's absolutely fine. We're always happy to hear. So use the email, use the helpline, get in touch via social media, join as a member or come to events. But really, we're here for you, and we will very much listen to what people want in terms of events, in terms of things that we're doing. So we really welcome feedback. So if you've got any ideas or thoughts of things that you'd like us to do, then do get in touch. But I think over to now to questions.
Fabulous. I'm going to dive right in. We're getting quite a lot of questions about diagnosis procedures. So it seems like maybe the talk has resonated with more than one or two people in the audience. So the first one is about the diagnostic process for children, basically. So it is basically the diagnostic process should be fairly simple. We're aiming towards a situation where every GP, every healthcare professional is capable of going, oh, look, you're hypermobile, the end. We're not quite there yet. So generally speaking, hypermobility is diagnosed often by rheumatologists. Often senior physiotherapists will pick up on it as well. Occasionally, if there's a suspicion that you've got one of the genetically testable types, you're going to end up under medical genetics or rheumatology, rheumatology, like genetic testing via that, basically. at the most simple level, basic level possible, you can walk into a GP surgery and say, look, my child is hypermobile, and they should be able to go, yes, I can see that. You've proven it right on the spot. With any kind of diagnostic process, there is often a little bit of variation. So people will end up with different diagnoses in different ways. Often it's by pursuing whatever the main symptom is. So if your main problem is musculoskeletal, probably going via physiotherapy is sensible. If your main problems are gastrointestinal, seeing a gastroenterologist is a sensible way to go. If your main problems are autonomic, as I suspect might be a common theme for a lot of people in the room, cardiology would be a good place to go. There is a huge amount of overlap. So if you are already seeing 2 or 3 of these specialists, approaching your GP and just going, look, all these things might be connected by this one really common sense kind of answer. My hope is that they'd be happy to go, yeah, okay, let's look into that. With anything, it's really important to recognize that your support should not be based on your diagnosis. It should be based on your clinical need. So whether you have a diagnosis or not, you are eligible for treatment for whatever symptoms you're presenting with. A lot of the people I work with don't have a diagnosis at all. That doesn't mean I'm going to say, oh, we'll come back in 6 months when you know what's going on. No, we're going to work on whatever situation you're kind of struggling with at the moment. So absolutely do pursue a diagnosis, but please be aware that a lot of the specialist centres, if your GP or your physio aren't confident diagnosing, the waiting times for specialists can be not fun. So in the meantime, my advice is always to focus on your self-management skills, focus on getting the right team of healthcare professionals backing you up based on your symptoms, rather than based on whatever diagnosis you're going to end up with at a later date. That should be exactly the same for kids. The difficulty is a lot of the specialists don't work in pediatrics. So you may find there's a little bit of a service gap, particularly for teenagers. That doesn't mean you can't get the appropriate support. It just means that diagnostically, maybe it's not such a simple journey. But please don't wait until you have a diagnosis to start accessing appropriate healthcare. Okay.
That's like really great advice. Absolutely. You know, yeah, couldn't agree more. Thank you for that. Do you want me to, are you happy to, do you want to access the questions yourself, or would you like me to?
Yeah, I've got them up. I'm happy. Yeah, sorry.
Fabulous,
This is basically how I run my live stream. So I just dropped into live stream mode.
I love it. I'll have the night off.
So, if you're having a lot of troubling symptoms such as PoTS, gastro issues, chronic pain, and a diagnosis is really hard to get, who do you advise is best to see to get a diagnosis and be believed? I think I've kind of answered that one already a little bit, but yeah, really, if you look at that spider diagram, like focusing on the specialist that is the most use for your shoutiest symptoms is a really, really sensible approach. And if, when you have the capacity to do so, you can approach a GP and go, look, this is the shouty thing, we're dealing with that, but actually these 10 things also need dealing with. My hope is that it starts to paint a really obvious picture that there's something maybe genetic or full body kind of involved. But again, like, symptom management is a really good focusing point. I think the thing about diagnosis is that, yes, it's validating and it's really helpful, and psychologically it's a brilliant process. Physiologically, it doesn't change anything. So self-management, really just get the help you need to manage, to live, to exist. When you've got some free headspace, go about getting the diagnosis, is how it should work. Obviously, I'm a realist. That's not how it always works, but my hope is that that's how it will continue to work. Fingers crossed.
We do have a clinician's guide that we can pop in the chat box. You can print this sort of stuff off and take it to your GP as well, if they really will not listen. That's always a useful thing to do. So I'm not sure if I can pop it in the chat, but I'll see if I can do that. It's just a clinician's guide, so it gives them a guide on what to look for and how they can identify, and how they can diagnose, that sort of stuff. So hopefully I can pop that in there.
We can always add it as well to our the link in our YouTube recording. We can put it in the notes after as well, so that people who are watching recorded can also access it.
Okay, thank you.
Fabulous. The other thing to remember is that you are always entitled to a second opinion. There is no situation within NHS or private healthcare where you are not welcome to seek a second opinion. There's also a magic phrase I would like all of you to memorize, and that phrase is, please document that you've refused my request for referral. What this does is, legally speaking, make the person who refused your request liable for anything that happens as a result of you not getting that referral. And it's the sort of phrase that really makes doctors who are sitting on the fence swing towards doing the thing that you want to do. Kim? Hand up?
Oh, sorry, I didn't mean to do that.
Okay, you can just jump in. Yeah, no, cool, lovely. But yes, that's a really useful phrase to remember. Next question. I have PoTS and I would say have some symptoms of hypermobility, although not the normal. I've been doing athletics for years, so I've got naturally tight muscles. So I do have joint problems, but can't really touch my toes and things like that. Double jointed hands, swallowing issues, gastrodysmotility, patella maltracking, knee issue. There's quite a lot of bendy sounding symptoms there.
Yeah.
Do you think I should ask the doctor about HEDS or hypermobility conditions? Yes, I do. Yeah. One of the things about hypermobility is that our main kind of treatment approach is building muscle. And that's not going to change the fact that you're hypermobile, but it can mask it a little bit. So my original career before dropping out to do OT things was in outdoor adventure. I was a rock climbing instructor for all of my teens. I was really physically fit and really strong, and doing potentially dangerous hobbies, rock climbing, gymnastics, trampolining, dance, all of my bendy symptoms were kind of brushed off of, oh, well, if you weren't doing such dangerous things, you'd be fine. And the muscle tension covered a lot of it up. Some of the most hypermobile people I know score 0 on the Beighton criteria now. And part of that is because they've gone so undiagnosed and so unsupported that the only things holding them together now are muscle tension and determination. So what tends to happen when you've got a lot of muscle damage built up and a lot of muscle tension from being physically fit is that you don't have the same symptoms. What you can do is clearly demonstrate that you've got a full body something going on, because statistically, the chances of getting all of those things from separate conditions, not likely. So if you can go in and say, look, I've got all of these symptoms, here are the reasons why I'm not showing that level of hypermobility. Any doctor who is worth their medical degree should hopefully see those and refer you on, or offer you some support. Likewise, if you are under a specialist for any of the other issues, have a chat with them about whether there is a likely linking condition between these areas. I think when you start working with specialists, by the time you're under like 3 separate specialists, somebody somewhere should have asked the question about what the connecting factor is. And if that person has to be you, welcome to the club. But my hope is that once you've pointed that out, somebody will go, yeah, okay, probably connected. You may find the spider diagram useful for that, but also looking at the diagnostic criteria. If you can go in with a tick sheet and go, look, I've got all of these things, hopefully somebody will take that appropriately seriously and pay attention, and you'll get some support there. Okay.
Yeah, and it shouldn't make a difference, but the spider research comes out of Great Ormond Street in UCL, so that kind of has a bit of clout behind it.
Yeah. Can the gastrointestinal issues be so severe that it can lead to malnutrition and problems eating? Absolutely, it can. I work with quite a few people who are tube fed or central line fed, like TPN is a thing for some people. There is, in fact, a subset of people for whom the gastro issues are kind of more of a problem than the joint problems, which you wouldn't think based on the name of the conditions, but it is the way it goes. There tend to be kind of a larger percentage of people for whom the gastro issue is a bit more subtle. So food intolerances are a really common way for that to present, or like bloating, IBS type symptoms are really, really common. Likewise, if you've got a combination of issues, as an example, reflux, nausea, postprandial kind of crashes from PoTS, slow death motility, and then you start having jaw problems on top of that, your motivation for pushing through with meals becomes basically non-existent. So quite often it is a combination issue, but yes, that is a thing that can occur. There are some approaches that are proving quite useful there. Likewise with the PoTS, really small frequent meals rather than like big meals with a crash afterwards can be really useful. Some of the things I've done with clients involve things like putting your feet up or eating in front of a fan. So you're kind of cooled down as you eat. Salt on your food is probably something you're all doing already, I would imagine. Likewise, things like in the summer, if you are really struggling with heat intolerance, don't also try and chuck a meal in there as well. So meal replacement shakes can be a good way to compromise there. There's also a diet called the low FODMAP diet and low histamine diets as well, which have proven really effective for a lot of people. So they might be worth a little bit of looking into. The FODMAP one actually has its own app, so you can look up foods as you go about your day if you can't remember all the information about it. So super useful there. Okay. Is cracking joints a sign? I spoke to Dr. Gupta and told him about joints feeling like they need to be cracked and sore joints, and he said yes. Yep. Quite often there's different kinds of cracking joints. So the first kind is the kind of feels like a build-up of pressure and you just want that light kind of crunchy relief type thing. The most recent theory I heard about this is basically if you have an abnormally high range of motion, it can trap air bubbles in your synovial fluid, in the liquid between your joints. So when you crack them, what you're basically doing is using yourself like human bubble wrap. That's the simple one. The slightly more worrying one is actually what a lot of people think are crunchy joints are actually subluxations, which they're then putting back in joint without realizing, which is certainly what I did for all of my teens and 20s until I started seeing a decent physio and went, oh, that's how skeletons are supposed to work. My bad. But yes, effectively, it can be a thing. What you may find is that being like increasingly body aware about not hyperextending your joints during everyday tasks can cut down on the first kind. The second kind, the joint displacement issue, I would strongly suggest either working with a physiotherapist or checking out the wonderful Jeannie DeBon. Learning to kind of recognize where your body's safe movement areas are is a really sensible thing. So when I talk about joint protection, I talk about having a spectrum between every time you do this, you end up in A&E, and most of the time this is safe. We're trying to stay in the most of the time this is safe range of movements. Part of this often comes into the proprioception thing that Lisa mentioned briefly. So proprioception is your body's ability to work out where you are in relation to the rest of yourself, but also your environment. Part of what makes proprioception work is something called stretch receptors. So you work out whether your toes are pointed or whether your knees are locked out based on stretch receptors within your ligaments and your muscles. If your body thinks you're at full extension, but actually you've got your knees hyperextended, when you attempt to move, your body has the wrong starting information, meaning that you're much more likely to fall over or walk into a door or just end up in a heap somehow. So crunchy joints, part of the issue is that often we don't recognize that we're hyperextending all of the time. Just constant little bits of micro damage. So what we can start to do is either work on improving our body awareness, or we can try strategies like compression garments, or we can try things like kinesiology tape. One of the really good ones I get people to do is to actually do everyday tasks in front of a mirror so you can see yourself doing them and work out what you're actually up to with your own body during those tasks that are causing injuries for reasons we don't fully understand. So yeah, I hope that helps a little bit. Okay. Can you have EDS and lots of associated symptoms if it's not known whether there's a direct genetic link from the parents that you know of? This was a big debate around the time when they brought these new kind of I say new as if it happened last year. It's not new anymore. It's just new compared to the first route. Basically, what they were saying was that, you know, you're looking at family histories, but what that meant in the short term was that a lot of people thought that you then couldn't get an EDS diagnosis if you were adopted or didn't know your family history. What we're often looking for with the spectrum conditions is, as an example, I've never had a hernia or a prolapse. Has anyone else in my family had those? If so, as a family unit, we tick off all of the diagnostic criteria. So if you've got, say, yourself and 2 children who are hypermobile, you might each have a few symptoms. Not quite enough for an EDS diagnosis. But if you're looking at all of you together, that paints a really clear picture of the fact that there's something heritable, something genetic going on. If you don't have those additional family pictures, that information there, but you've already got the entire spectrum of symptoms, you don't need the family history at all. What can happen if you don't have that full spectrum is, so my original diagnosis was benign joint hypermobility syndrome, which isn't even a thing anymore because I didn't have any autonomic symptoms to start with. Well, in hindsight, I had a few, but I didn't have major ones. I didn't have major gastro issues. I didn't have any kind of like documented neck instability. When I got all of those things over the span of 4 years, it then became fairly clear that we were looking at hypermobile EDS. Nothing changed about my treatment at all. It was literally just that they swapped the letters over in some of my clinic letters. So essentially, you will be diagnosable as something. What you get diagnosed as shouldn't be dependent on this. If it does, it kind of sort of shouldn't matter because treatment's going to be the same regardless, because it's all based on clinical need rather than which letters they stick on your diagnostic report. So hopefully that's helpful. Okay, what have we got left? How are we doing for time? Should I just keep going until we run out of questions?
Yeah, I mean, it's up to you guys how for time wise. Obviously, it's if you're happy to carry on for a few minutes, then that's great.
Happy to keep going. No worries.
Thank you.
Okay, lovely. I was diagnosed with HSD by a rheumatologist and immediately discharged. Are there any clinics or clinicians that offer ongoing care for joint pain or subluxations? This tends to be the case. Rheumatologists will go, you have this thing. We can't fix it with drugs. Good luck on your own. That's probably a fairly standard approach. A lot of what a rheumatologist does is look at medication approaches for things like autoimmune conditions, and that's not a thing that helps us. So what you would be looking at would be finding specialists for whichever symptoms are much of a problem. Things like pain and subluxations, you'd be looking for physiotherapy, and you would be looking for pain clinic as 2 options. Or find yourself a friendly neighborhood occupational therapist and start from there. A lot of the time, approaches like working with Jeannie DeBon can work well, and then pain clinic as a standalone item can be quite hard to access in some areas. But pain clinic is basically made up of physio, OT, somebody prescribed drugs, and some kind of psychological support. So if you can't access pain clinic, but you can access the individual components, you're going to get the same support. It just might take 3 or 4 referrals rather than 1. So yeah, effectively, support should be available. In most areas in the UK, you can now self-refer to physiotherapy. You don't even have to see your GP. So if you put in your postcode and physiotherapy self-referral, you can get yourself sent over. In that referral, I would document everything you've got going on in great detail and request that you see somebody who has experience with hypermobility as part of that referral. If you end up with a physio who doesn't have experience with hypermobility, whatever they recommend, do 1/3 of it at 1/3 of the intensity and build up gradually. Because the major key mistake I see physios make is just going in too hard and too fast. Other than that, treatment is basically the same for non-hypermobile people. We just need a gentle start because we're delicate flowers who fall apart too easily. Lovely. Okay.
While Joe's looking, I think that's a really common issue that you get, you know, the rheumatologist discharge you to. So we're trying, and Kim and Dr. Bull have been putting a guide together for GP, so they're much clearer on what to do next, you know, what the referral pathways are. But again, it will take time. So in the meantime, just follow Joe's advice.
Thanks. Is there any guidance or advice for patients whose doctors don't believe them, either for diagnostics or treatment, e.g. anesthesia resistance or MSK issues? Anesthesia resistance should be fairly simple. If you ever need surgery, talk to your anesthesiologist, who won't be the same as the GP or doctor who doesn't believe you, and they probably will believe you. And that they have an active part in that anyway. For something like dental work, where you're looking at local anaesthetic resistance, what I would say is come up with a series of, basically I've got like hand signals with my dentist. So if I raise my left hand, I need a break because my neck or my jaw or my back hurts. And if I raise my right hand, my anaesthetic is worn off and I want more drugs, please. That kind of thing can be a really simple communication you do with the individual. It does not need to have your unhelpful, disbelieving GP involved. Likewise, the phrase I used earlier, can you please document that you refuse to help or you've refused offers of support, is a really useful thing. In terms of MSK issues, self-refer to physiotherapy, skip your GP altogether. Your physiotherapist can then report to your GP that you've done that, and hopefully the physio will agree with you that there's something obvious going on, which will be further ammunition to fight with your doctor for other issues. You can always ask for a second opinion. If they're telling you you can't have a second opinion, contact the practice manager or contact PALS, because you are well within your rights and there's absolutely nothing they can do to stop you from doing that. And I'm sorry you have to put up with it. Okay. What mobility aids are best to use? That very much depends on what mobility issues you are having. Ideally, I would like to give everyone all of the mobility aids so that on any given day they can choose which one they want. But short of having a shipping container with £10,000 worth of mobility stuff in it, basically what we start looking at is, what do you want to do with your life? Where do you want to do those things? And what is currently stopping you from accomplishing it? So if you are looking at pain in one ankle, stopping you from walking on flat ground over short distances, crutch might be all you need. If you are looking at bilateral pain in multiple joints below the waist, and you've also got a shoulder problem and you want to go up a really steep slope for 2.5 miles, power chair might be your best option. You can have all of those options. So I'm a part-time wheelchair user. I've also got crutches. I've also got a long white stick for use when I'm walking at night and I can't see a thing. You don't have to just pick one thing. If you want support working out which of those to try, there's a really brilliant event called NAIDEX, N-A-I-D-E-X. It happens at the NEC in Birmingham every year, and it is a massive disability roadshow of all pieces of equipment. It's the best possible option for trying out every single mobility aid on the market. It's a free event, and the NEC also has mobility scooters you can hire for the day. I would, if you are going to go for it, suggest making friends with the people there exhibiting beds, because it's a really great place to go and have a lay down halfway through the day when you run out of energy. I definitely do that every year. But yeah, try some stuff out, see how it feels, but really go back to basics with what's stopping you from mobilizing without an aid. What do you want to do with it and where are you doing it? And hopefully that will give you some answers. Okay. What's the difference between HSD and HEDS? It's not about the severity of symptoms, it's about the variety of symptoms. So you can be, as an example, really severely impacted by MSK symptoms, but not have the whole suite of other associated issues and get an HSD diagnosis. You can be very mildly, barely at all impacted by a wide range of little things and get an EDS diagnosis. Often the only thing that makes the difference is which doctor you see. Like in most cases, it's borderline negligible. And being focused on like treatment and interventions, as I am for my job, it should not make a difference at all to any of your treatment. But effectively, it's about the range of symptoms that you demonstrate as an individual. That's it. You may find that changes. A lot of people at the onset of symptoms don't have the same variety of symptoms that they will have 20 years down the line after they've had a kid or changed lives or moved house or been in a car crash or done 10 years of outdoor adventure that probably wasn't sensible, as an example. So these things can change over time as well. So yeah, it's a bit of a vague kind of thing, really. Okay, lots of questions. This is going to turn into a whole live stream if I'm not careful. Okay, I have PoTS and have been diagnosed with HEDS, but didn't have many symptoms other than being bendy. The last years, my knees click and crunch loudly going upstairs. Could this be EDS or more likely osteoporosis? I'm in my 30s, thank you. Unless you've got a really alarming family history and you went through a very early menopause, I would be surprised if it was osteoporosis. Osteoarthritis is a possibility, but honestly, probably it's a bendy thing. A lot of us get quite crunchy if your muscle tone is not particularly well balanced and you are less mobile. As an example, you're not hitting the gym quite so often because you get wildly tachycardic and severely unwell. Might be an example. Your best bet would be a self-referral to physiotherapy. If they are concerned, they can then refer you directly for imaging, testing, scans, etc., to check for anything else that's alarming going on there. But crunchiness in your 30s is a fairly classic kind of hypermobile knee type situation, I would guess. If in any doubt at all, please see a GP though. Get yourself some x-rays just in case. Okay. Generally speaking, if you're having troubling symptoms, e.g. GI symptoms that are caused by hypermobility, do diagnostic tests come back as normal? Inconclusive is the classic result for hypermobile people. Well, there's something vaguely wrong with you, but we kind of don't know what it is. Yeah, it's quite common for things to be either intermittent or to be not specifically alarming enough to be diagnosable. You may find that your symptoms fluctuate quite wildly with various other variables. As an example, if you are particularly stressed, your digestion will get worse. Or if you are particularly kind of heat intolerant, your digestion's worse in the summer or things like that. So yes, that's a fairly classic response, unfortunately. That said, it doesn't mean these things aren't treatable. Gastrointestinal stuff in particular, there is a really, really, really wide range of very cool and effective medications that might be of some use. So the other thing you can look at are diets to work out whether there are like food triggers that are causing these problems. So a referral to a dietitian would probably be sensible, and speaking to your GP about possible medication options. If they're not happy with that, a referral to gastroenterology would be sensible. If gastro don't know what to do with you, then find a specialist gastroenterologist. There are also quite a few dietitians who are now like bendy specialists just through necessity, because bendy people had to get advice somewhere. So if you look for people that are hypermobility, like dietitian specialists, they're probably going to be the best place to help. Two things. Okay. Do subluxations always hurt? My jaw cracks and feels stuck out of place sometimes by doing something as simple as brushing my teeth, but it goes back in without it really hurting. That's kind of a weird sweet spot for hypermobility. I've got that point with my wrists. Most of my other subluxations hurt. My wrists are just inconvenient at this point. If you get to the point where a ligament is so stretched out that you physically don't need to cause any soft tissue damage in order to get the two bits of your joint to not be in the right place, you can have borderline pain-free subluxations. The only way to 100% be sure that that's what's happening is if it physically happens whilst a doctor is holding onto your face, or it happens in an MRI machine. Yeah, it might be. I can't tell you, but yeah, it's a thing that can happen with some people. Yeah, teeth brushing. My last like 10 jaw injuries were either brushing my teeth or eating pizza. Like it's always the things that you think are safe and innocuous that end up with ridiculous injuries.
Joe, I'm just wondering, because there are so many questions still left to go, whether we ask them to bring them to your next live stream, or we can answer them as our first questions.
Yeah, no, that's a really good idea. And I realise now, badly, the link isn't up on our website yet, but I will do that this evening so that if people want to sign up for the next Ask the OT, they can do that. They can register for free on our website for November 21st. Bring your questions, because I'm just conscious that we could be here forever.
You'll be here forever, yeah.
Yeah, you know, absolutely, just so fascinating, so informative, and such great questions as well. You know, I think it would be great if people do come to your session, because I think there's so many things that, you know, that they'd still like to be covered. We will put the link to it as well in our YouTube, and then people can keep finding the monthly sessions as well. And we'll also email it out to everybody as well, so that they've got it and can join that session, because it's really fascinating to hear you talk. It's you can see your passion, and clearly as well your amazing knowledge of it, all of you. So just thank you so much for giving up your time this evening and answering all those questions. Really sorry to those of you who we haven't had chance to answer the questions, but do definitely join Jo's session on the 21st of November, and I'm sure she'll be
we'll
happy
make sure we'll put them down as pre-asked questions as well, so they get answered first.
Yeah, if you could send us the chat with the remaining questions, we'll put them so that they definitely get asked, and then people can, if they register for the session, even if they can't make it, they'll be able to watch it on playback.
Oh, perfect. I was just going to ask that, whether they're recorded. So, okay, brilliant. Well, thank you again to the HMSA team for joining us tonight, and thank you to everybody as well for giving up your evening to come and join us. Hope you've learnt lots. I know I absolutely have. Yeah, we'll look forward to working together more as charities in the future. Thanks, everybody.
Thank you, everyone. Thank you.
Bye.
Bye.